My name is Dr. Ziad Al-Rubaie from the University of Notre Dame, Australia. I'm going to present my research, predicting pre-eclampsia in nulliparous women using routinely collected maternal characteristics, a model development and validation study. International antenatal guidelines, including NICE in the United Kingdom and Australia, recommend pre-eclampsia risk assessment to guide preventive care. They provide risk factor lists to identify high-risk women, but do not provide an explicit approach for combining common moderate risk factors measured on a scale such as age and BMI to estimate a woman's risk level. One of the major risk factors for preeclampsia is a woman's prior pregnancy history. Thus, it is more challenging to identify women at high risk of preeclampsia in their first pregnancy. Few studies of preeclampsia risk assessment tool have targeted this group. So the objectives of our study are: first, to develop and validate a preeclampsia risk prediction model for nulliparous women. Second, to compare the model's performance against the existing NICE approach. Methods. This was a retrospective cohort study. We included nulliparous women who gave birth in 2011 to 2014 in Western Sydney local health districts in Australia. Study data were extracted from a district-wide clinical database. We split the sample into two cohorts. We included women giving birth in 2011 and 12 to develop and internally validate the Western Sydney model using multivariable logistic regression. We included NICE listed risk factors to build model. To optimize prediction of preeclampsia from age, BMI, and other NICE listed moderate risk factors, we developed a Western Sydney-based model, then added high risk factors. We externally validated the model in the second cohort of women, and then fitted the final model to the entire sample as outlined on this slide. Results. The study data included 12,395 nulliparous women. The calibration plot in the external validation sample indicates an acceptable level of calibration as shown in this plot of the predicted versus observed probability of preeclampsia with an observed expected ratio of 0.91. 8 predictors were included in the final Western Sydney model. The AUC of the final model was 0.70, indicating good discrimination. The final model identified 1 in every 5 women with preeclampsia had risk estimate above 8%. Higher model sensitivity were estimated when assigning a lower risk thresholds. Using the NICE approach, the sensitivity was 37% and specificity 91%. At the same specificity estimated by NICE approach correspond to 3.8% risk, the final model achieved a similar sensitivity to the NICE approach. Limitations of our study. We collected the study data from an existing clinical database. Misclassification might lead to underassertment of study variables and underestimation of their predictive performance. Furthermore, we did not include births from private hospital, which would reduce the applicability of the Western Sydney model. Conclusions on clinical and research implications. A risk prediction model that incorporates guideline listed risk factors and ethnicity provides modest performance for predicting preeclampsia in Australian nulliparous women. The model did not outperform the NICE approach, but has the advantage of providing individualized risk estimates over the NICE guideline to assess patient counseling and inform decisions for further testing and prophylaxis. For research, the model should be validated in other Australian health settings before implementing in clinical practice. The Western Sydney model could also be used as a foundation on which to build a risk prediction model that includes clinical